that I've been in HIM 25 years. I'm like, I refuse to think that I'm like that old. There's like no way. But back then, we did not have the luxury of having, you know, webinars like we do now. So it's just great that we have technology where we can connect very easily and affordably for CEUs. So I'm happy to be able to speak to those of you in the northern part of the state today. So our topic for today is biopsy, aspiration, and drainage. That's going to be the main focus of the webinar. And then I'm also going to touch on sclerotherapy coding a little bit. And I include that with the aspiration and drainage because sometimes they're done during the same session. And also with sclerotherapy, it tends to be a confusing area of CPT coding still, just because you have many different code options and there are a lot of factors that go into play. But the first thing we're going to look at today are biopsy procedures, then we'll roll into aspiration and drainage, and then we'll talk about sclerotherapy, and then I'm briefly going to touch on moderate conscious sedation, because all the procedures that I'm talking about this afternoon, that you would bill moderate conscious sedation with all them. So I wanted to tag that on to the end, and really for that, just focus on, you know, documentation pointers, if you will. So let's jump into biopsy coding. So when we're talking about interventional radiology, our biopsies that we're coding are going to typically be fine needle aspirations, or they're going to be core needle biopsies. These are the percutaneous biopsies. And essentially with biopsy, what you need to determine in looking at your report is whether or not you have a core needle biopsy, or you have a fine needle biopsy, or that fine needle aspiration. And sometimes in reports, it's not always crystal clear. It still amazes me that even with some of the simple procedures, or procedures that should be simple to code, sometimes it's a little bit challenging because the documentation is not clear. I know that there's one client that I have worked with for a while where they will do biopsies and they will not call it a fine needle aspiration biopsy, nor will they call it a core needle biopsy. But how I know that they have done a fine needle aspiration is based on the fact that they are aspirating cells from the sample, and then they are sending that for cytology. So that, the majority of the time, is going to indicate that you have a fine needle aspiration biopsy, as opposed to a core biopsy where they use a special needle that actually cuts out a core of tissue to perform the biopsy, and then they send that for histology. So those are, if the report is not clear as to whether or not it's fine needle or core needle, then those are some clues that you can look for. When they send it to pathology, are they doing cytology analysis? Are they looking at cells, the fluid, or histology? Are we looking at a tissue sample? So that's something that you could use to help you work your way through that. So with the biopsy, the needle biopsy that they're doing, they might use that fine needle, you know, biopsy, or they might use a larger gauge cutting needle. Where you want to make sure you don't make a mistake is that you are making the determination of the type of biopsy code you're assigning based on the size and gauge of the needle. That is not what determines it. So you may have a fine, you know, needle, or a smaller needle biopsy, and it not actually be an FNA as far as coding is concerned, because the core can be obtained with any size or type of needle. So that's what you want to remember. So that cannot be used to make the determination. And then for the core needle biopsies, we have a whole list of anatomical surgical codes that we can choose in order to report the biopsy. And then we also have guidance codes that we'll look at as well. And only when an anatomically correct needle biopsy code does not exist, and when an aspiration is performed rather than a core, should the fine needle aspiration code be reported. So that is also something that you will look for in your documentation. So here is a list of our needle core biopsy codes, and I'm just going to highlight a few of these. You know, obviously the list itself is self-explanatory, but I just wanted to point out that 20206 for a muscle biopsy, that 20206 is also commonly utilized for soft tissue biopsies, and that can be anywhere in the body. If you have a soft tissue biopsy that is not specifically described by a code, then you would use 20206. That's the generic code for that. Then we also have code 38505, which is for lymph nodes, but these are superficial lymph nodes. So this would be your cervical lymph nodes, your axillary lymph nodes, your inguinal lymph nodes. However, sometimes the physician may be biopsying an abdominal lymph node. If that's the case, if there's an abdominal lymph node that they are sampling for biopsy, that actually would be reported with the abdominal code, the 49180. So that 38505 are for those superficial lymph nodes. If it's deeper and they have to go into that abdominal, peritoneal, retroperitoneal space, then it's a 49180. So those are really the couple of things that I wanted to point out here. And then commonly with the thyroid biopsies, you'll see here that the code is 60100 for a core biopsy of the thyroid. But the majority of the time, the thyroid biopsies are actually done as fine needle aspirations. So typically it's not going to be coded with the core code, but it would be an FNA. So that's just something that you'll want to keep an eye open for. So of course, with the needle core biopsy codes, we have a choice of our different guidance codes that we will assign with the correct surgical code. So if we have ultrasound guidance, we have a code, fluoroscopic CT, and then MR guidance, which are self-explanatory. And throughout the presentation today, I've inserted some NCCI language from the NCCI Manual, because sometimes what I find when I'm doing audits is that some of the language in the NCCI Manual is overlooked with coding. Just because you have the ability to bypass and edit by using an NCCI modifier doesn't mean that you should do it. And I see that a lot in coding, regardless of what settings I code in, whether it's physician, hospital, whatever the case may be. Sometimes coders and billers fall into the habit of, oh, this needs a modifier on there, I'm going to put a 59 on there, or if you're using the X modifiers, whatever the case may be. But just because it's permitted doesn't mean that you should be doing it. So I've taken some information about these procedures out of the NCCI Manual for today's presentation. So with these guidance codes that we just looked at here, CMS allows payment for 1 unit of service for all of these codes for a single patient encounter, regardless of the number of needle placements performed. So the unit of service that you will be reporting for these codes, it's the patient encounter, it's not the number of lesions. Now with the biopsy codes, we will report biopsy codes for each lesion. You have the ability for each separate lesion to report a biopsy code. But when it comes to the guidance codes, these are not reported by the separate lesions that you are actually biopsying, but it's going to be based on that encounter. So it's going to be one time you will assign the guidance codes, even if you have the biopsy code assigned multiple times. And that used to not always be the case. We used to be able to report the RS&I code in addition to the surgical code. So you want to make sure that that's one time for the single patient encounter. So as I just said, biopsy codes are assigned one time per lesion. You will not assign more than once for multiple passes of the same lesion. So whenever you are reading a report and they're taking multiple samples, you want to make sure that you need to determine if those multiple samples are coming from one lesion or if they're coming from multiple lesions, and then assign the biopsy codes based on that. And then the guidance codes will be assigned one time per session. And then just a side note here, if you have a biopsy, say with a prostate biopsy, you might see this. They may do 3D rendering for mapping of locations. That's not reported with the 3D rendering code. So that's not the use of those codes, so there isn't anything to report separately for that. So with the fine needle aspiration, we have two code choices. We have 10021, which is an FNA without imaging guidance, and then we have a 10022, which is an FNA with imaging guidance. So if your interventional radiologists are doing these, they will probably be doing the FNA with imaging guidance. Very rarely do I see an FNA without imaging guidance. I can't even remember a recent time seeing one in the reports that I review. Because if they're going to interventional radiology, it's because they need some type of imaging guidance. So with the FNA, most commonly you'll see the fine needle aspiration done for a thyroid, a breast, the prostate, the lung, or the liver. Those are some of the more common, with thyroid being the most common. Of course, you can do core biopsies of all those, so that's why it's important to pay attention to the documentation. With the fine needle aspiration, typically it will be done with a fine gauge needle that's 22 or 25 gauge. But remember what I said a few moments ago, you can't rely on the size of the needle alone in order to determine whether you have a fine needle aspiration or you have a core biopsy. But with this fine needle aspiration, what you're looking for is that the physician is obtaining fluid from either a cyst or cells, from a mass, and then it's sent to pathology for analysis. They're actually doing cytology on that sample. Also from the NCCI Manual, it has some instruction about coding fine needle aspiration with a core biopsy. So sometimes you'll see a fine needle aspiration performed during the same session as a core needle biopsy. And in the majority of those cases, that aspiration is going to be bundled into the core, and there wouldn't be anything separate to report. However, there are instances where you may report both the fine needle aspiration and then also the core biopsy. So basically what you're looking for in those reports is if they do a fine needle aspiration and then they determine that that specimen is inadequate for diagnosis, a lot of times they have the ability to assess adequacy of that aspiration when they're doing the procedure before they ever send it anywhere for analysis. If they determine that it's inadequate for diagnosis and then they decide based on that to do a core biopsy, then you have the ability to report the FNA in addition to the core biopsy. However, if the specimen was adequate or if they don't mention that it was inadequate, necessitating a core biopsy, then you would only report the core biopsy and you would not report the fine needle aspiration. Also in the NCCI manual, it says the unit of service for an FNA is the separately identifiable lesion. If a physician performs multiple passes into the same lesion to obtain multiple specimens, only one unit may be reported. So we see that this is just a reiteration of the rules that we were talking about with the biopsy codes. So this also applies to the fine needle aspiration code as well. So throughout the presentation, I've just thrown in some very brief case studies. Some of them are super simple. Other ones, I think, give you a little bit more complexity. This one that we're looking at on slide 13 is just a basic CT guided lung biopsy. And you'll notice there that it was done under the CT fluoroscopic guidance and a total of 3 core samples were taken. Because 3 core samples were taken, it's still just of the one lesion, then we're going to code for the lung biopsy one time, 32405, and then our guidance is 77012 for CT. The next one is an adrenal biopsy. And if we look at our list of codes for a percutaneous needle biopsy, we don't see adrenal on the list anywhere. It's not an option. So how do we code for an adrenal biopsy? We would code this as an abdominal biopsy 49180 because this is actually contained in the abdomen. Don't make the mistake of coding it as a renal biopsy. The adrenal, although it's attached to the kidney, is not the kidney. It's not a kidney biopsy. So it would actually be an abdominal 49180, and then this was performed under CT guidance. So that 49180 can be used for multiple abdominal structures. Like I mentioned earlier, if you have an abdominal lymph node, that would be coded with 49180 and not the 38505. So that can catch many different things that are biopsied in the abdominal area. So now we're going to talk briefly about breast biopsy coding. And with breast biopsy codes, they changed these, gosh, several years ago now. I can't even remember when they changed, but for many years we've been using these, and we no longer have to report a surgical code and an RS&I code. We have our surgical codes, which include that RS&I component. And then also within the code description, it's specifying what, ooh, I see that I have the wrong code description there. No, that's right, breast, got it, okay. In the code description, We have biopsy breast with placement of breast localization device. So we see with these code descriptions here that our localization device is going to be bundled when the physician performs the breast biopsy, and that can be any type of localization device that they happen to be placing. And then also imaging of the biopsy specimen, that would be imaging done where they would do take the x-ray, film of it, or maybe do ultrasound, looking at the specimen. That's all going to be bundled, and then we assign our codes based on the type of guidance that's being used. That's how these are structured. So you see that we have 19081 with stereotactic guidance, and then we have the add-on code for each additional lesion under stereotactic guidance, and then we have codes for a biopsy under ultrasound guidance, and then also the MR guidance as well, the magnetic resonance guidance. So with the breast biopsy codes, we need to determine what type of guidance was used in order to select the correct code. So the three codes that we just looked at, or the three code pairs, I should say, because we had a primary and we had an add-on code for each type. We have codes for stereotactic, for MR, which is of course the magnetic resonance, and then ultrasound. What you might be seeing now, this is something newer, and I started seeing this recently with a client, where they are using tomosynthesis guidance for the procedures. We do not have a code in order to report a breast biopsy with the tomosynthesis guidance, so that would be reported with 19499. So basically, any other type of guidance that would be used that isn't stereotactic, the magnetic resonance or the ultrasound, would be 19499 because we don't have a code for that. As we just saw, we had add-on codes for multiple lesions, and it includes that breast localization at the site. And what's nice about these codes for breast biopsy is that there's no distinction for the type of biopsy. With the old codes, we had to look at the report and determine, for example, whether we had a core, whether we had a vacuum assisted, and the reports weren't always 100% clear. I can remember always doing sessions on breast biopsy coding and providing coders with like a list of like all these buzzwords and clues if the physician didn't label clearly the type of biopsy, how to be able to arrive at that. But now it's just based on the type of guidance and then the number of lesions that they are biopsying. Localization is included, and then with the codes, because we have a primary code and we have add-on codes, the primary codes will be used one time per session. So even if you're doing, the left breast and the right breast, it's not one primary code per breast. It is one primary code for both breasts and then an add-on code. And then if you have a situation where they're using multiple modalities, say that they did, one biopsy under stereotactic guidance and then they did one under ultrasound guidance, then you would use one primary code per modality. So you would use primary code for ultrasound guidance and then primary code for stereotactic. So the only time you're going to have two primary codes for breast biopsy during the same session is if they're a different type of guidance. Otherwise, it's one primary code in the session. And then, of course, any imaging of the specimen, code 76098, that is going to be included with the breast biopsy, and that's something that we used to report separately with that. So moving on, we have our breast localization coding. So sometimes they'll place a breast localization device without doing a biopsy, and this may consist of a wire. Typically you'll see them place, they might place a clip, maybe radioactive seeds, whatever the case may be. These are the codes that will describe that. So this is when breast localization is done independent of a biopsy. If breast localization is done with a biopsy, then it's going to be included with the biopsy of that lesion. And you'll see once again that these are also structured with a primary code and an add-on code. And then you also select the correct code by the type of guidance. And the rules are the same. Primary codes, you'll use one time per session, and then multiple modalities, one primary code per modality, just like the biopsy codes. So there really isn't any difference from the biopsy to the localization codes, other than the fact that you do have the ability to report separately with breast localization any surgical specimen x-rays, and then if it's done via ultrasound, that's 76499. So if you're doing a surgical specimen ultrasound, it's not reported with 76098, it's reported with 76499, which is a clarification that the AMA had come out with on that. So we do have some NCCI language in the manual about post-procedure mammography, and this seems to like change like every other year, I swear. It just gets so crazy to try to keep up with it as far as what is permitted and what isn't permitted. So the latest version says, if a breast biopsy, needle localization wire, metallic localization clip, or other breast procedure is performed with mammographic, so that would be mammographic guidance, the physician should not separately report a post-procedure mammography code for the same patient encounter. The radiologic guidance codes include all imaging by the defined modality required to perform the procedure. And I should have updated on the slide there what the current codes are for mammography now. Obviously, we had changes in mammography codes at the beginning of this year, but regardless of what the mammography codes are, the rule is the same there. So that radiologic guidance code would include all of that imaging. So we're talking about mammographic. So that means with the other types of guidance, then you do have the ability to report that. But let's look at it in this context here. If we're applying NCCI language to our scenario, what happens is with facility coding, it is bundled. You're not going to report that post-procedure mammogram in this instance that's specified in the NCCI manual. However, if you're billing for the coding and billing for the radiologist, that professional component, and the radiologist that's reading that did not perform the biopsy, then you have the ability to report that professional component. And then if you're in the non-hospital setting, an order is going to be needed for that post-procedure mammogram. You know, that gets into the whole can of worms about the rules for diagnostic test orders, which we have a big difference in what's permitted in the hospital setting versus the office setting and in an independent diagnostic testing facility. That in and of itself is a whole program where I could talk probably for about 45 to 60 minutes just on test orders and that kind of documentation. So here, this is just a review, the FNA versus core biopsy that we looked at. So this is just carrying information forward from prior slides. And the reason why I put this in here into the breast biopsy section is because you may have instances where you are assigning the fine needle aspiration codes for the breast, for samples that are being taken from the breast. So that is just a review of what we've seen on prior slides. And then breast cyst aspiration, we have specific codes for the aspiration of the cyst of the breast. We have 19000, which is primary, and then we have an add-on code for each additional cyst. And then with this, you're going to use the primary code once per breast. So where with breast biopsy, we use the primary code once, even if we did 2 breasts, here for the puncture aspiration of the cyst of the breast, you can use that code, the primary code, once for the left and once for the right, and then you would assign the appropriate imaging guidance code with it as well. And then if they had done a localization ultrasound prior to doing that, then you would not code for the localization ultrasound. So I have a couple of examples of a breast biopsy. So this one that we're looking at, straightforward, we have under ultrasound guidance, 3 passes of the 14-gauge core needle biopsy device were obtained with documentation of the needle within the lesion. The specimen was sent for pathologic analysis. Following the biopsy, a titanium clip demarcating the biopsy site was placed. Patient tolerated the procedure well. So we assigned the code for the biopsy. The placement of the clip is actually going to be bundled into the biopsy, so there's nothing further to code with that. And then in the next example, this is one that is a breast biopsy that's done under the MRI guidance there. And also it says a titanium clip is placed. And then we see towards the end of the report that CC and MLO views were obtained. So we have our post-procedure mammogram prior to discharging the patient. So because this was under MR guidance and it wasn't under the mammographic guidance, we have the ability to report the breast biopsy in conjunction with, I'm sorry, the post-procedure mammogram in conjunction with the breast biopsy code. So now we're going to move on to aspiration procedures. And I think sometimes the biggest issue with coding these when we're looking at aspiration also involves drainage and determining, do we have an aspiration, do we have a drainage, which code are we going to choose? So hopefully after I go through the aspiration section and then we jump into the drainage section, that will be a little bit more clear. To make sure that we're assigning the correct code, the documentation really has to be complete. And I know sometimes documentation can be lacking. But basically with an aspiration, that is going to occur when you have fluid that is sampled, or they can also be instilling fluid as well at the same time of an aspiration. So when they're doing an aspiration, they could be inserting something as well as aspirating something. And the aspiration can be performed with that fine needle, the FNA that we talked about, or with needles of a larger gauge. So once again, the size of the needle has no bearing on whether we're coding the FNA code or we're using a core biopsy code. And just like with our core needle biopsy codes that have many site-specific CPT codes, we also have site-specific aspiration codes. If you have a situation where you don't have a site-specific aspiration code, then you have two options to consider. And that's a puncture aspiration of an abscess, hematoma, bulla, or cyst. That's kind of like a catch-all code. And then we have the fine needle aspiration code, assuming that what was done is indeed a fine needle aspiration and is documented as such. So with the fine needle aspiration biopsy, to just kind of review, because it falls under this aspiration category as well, when you will see that they will remove superficial tissue from the thyroid or the breast or prostate. That's typically where it'll be done. And then if they're going deeper, then you have the radiology guidance. And once again, here are your codes with a summary of what you're seeing for the type of work with an FNA. So I won't repeat that. So moving on, so aspiration, we have a lot of aspiration procedures that don't necessarily say aspiration or use that terminology in the code description. But when we see the centesis procedures, these are aspiration procedures. So for an abdominal paracentesis, these are very common with the interventional radiologist performing these. We have the abdominal paracentesis codes. These are for either a diagnostic or a therapeutic abdominal paracentesis, and we have one code which is for an abdominal paracentesis without imaging guidance, and then we have 49083 with imaging guidance. So if the interventional radiologist is doing it, chances are he's doing it with imaging guidance 49083, and then that's the code that you're seeing more commonly assigned. And basically this is just removing fluid from the abdominal cavity, whether it be to send for analysis to make a diagnosis, or it's therapeutic where they have to remove it, or maybe even a combination of both. And then what you'll see with these procedures is that they will do localization images. Let's say ultrasound, localization. That's typically what they're using for these. The localization images are going to be bundled into the abdominal paracentesis code there. But if you have a situation where they do those localization images, which basically is limited ultrasound imaging, if they determine that there's no fluid, then you will report code 76705 for those localization images if they determine there's no fluid. And that does happen from time to time, where they send the patient for an abdominal paracentesis, and then when they do that localization imaging, they say that there's no fluid. So whatever had been there isn't there, or whatever they suspected isn't there anymore. So that is what you would do with that situation. And then we have code 49084, which kind of gets lumped in with these codes, sort of. What this is for is when a patient, let's say they come in and they've been experienced trauma, they're in a car accident, and then they have blood that's in the abdominal cavity, then they will actually remove that from the abdominal cavity. And so that's the code that you would be looking at there. So in this example, this is an ultrasound guided paracentesis. So it's very straightforward, where it tells us that using ultrasound ultrasound guidance, a 6 French catheter was placed into the peritoneal cavity, yielding 10 liters of serous fluid, ultrasound guided paracentesis without complication. So what you'll see in a moment when I get to this section on drainage is that the key difference between aspiration and drainage is that with an aspiration procedure, the catheter or the needle will be inserted into the collection and then it will be removed at the end of the procedure. And then with a drainage procedure, the catheter or needle goes in and then it remains in place at the end of the procedure for continuous drainage. So if you have a report and it doesn't indicate that a catheter has been left in place, let's say it's not clearly documented exactly what it was, that's what you'll want to look for. Did the patient leave with the catheter or did they not? If there isn't clear evidence that they left with the catheter in them, then it probably is going to be an aspiration procedure. So this one is very straightforward, an abdominal paracentesis, the 49083. So another aspiration code we have is a thoracentesis. And so this is going to be removal of fluid from the pleural space. And so we once again have a code without imaging guidance, and then we have a code with imaging guidance, which is 32555. And like the paracentesis, often they will do these under ultrasound guidance, and then they will possibly, once again, see that there's no fluid when they're doing the localization images, and then if not, then you can code 76604 if you don't do the thoracentesis. Otherwise, those localization images will be bundled with a 32555, just as they would be with the paracentesis with the 49083. So here's some information from the NCCI Manual. So this pertains to pleural drainage, also thoracentesis, chest tubes, so on. It says a pleural drainage procedure, we didn't get to that yet, but we will in a moment. Thoracentesis procedure or chest tube insertion procedure is often followed by a chest radiologic examination to confirm adequacy of the procedure, lack of complications, or the proper location and positioning of the chest tube. A chest radiologic exam should not be reported separately for this radiologic examination. So if it's simply to do that check when the drainage catheter is placed or a thoracentesis is performed or a chest tube is placed, it's not going to be coded separately. There has to be a reason. You have to have a medical necessity for any chest x-rays that are going to follow any of these procedures. So if it's routine where they're doing it to confirm that procedure, then that is what you're going to have them bundled. You're not going to code anything separately for those. So that's something that you'll want to watch for. So here's an example of an ultrasound guided thoracentesis. Here, it tells us that ultrasound images of the right thorax were obtained to localize large rate of fusion. Then we see that the needle was advanced into the pleural space, fluid was aspirated, and then it says the pigtail catheter was passed through the skin into the fluid, and then they aspirated more fluid before the drainage was ceased, and then catheter was removed and sterile dressing applied. So based on the documentation here, even if they had not specifically said it was a thoracentesis, just looking at the work in the report, we would know that this is not a drainage, that it is an aspiration, and that we would assign the thoracentesis code 32555. So bone marrow aspiration, we actually have a change that is going to occur in 2018 with bone marrow aspiration. So I'm still going to include this. I'm going to talk about it briefly because we're coding them for another 6 weeks or so. And then I have a slide in here for 2018 and what that'll look like. So currently we have 2 codes. We have 38220, which is for a bone marrow aspiration. And then we have 38221, which is assigned for a bone marrow biopsy. So with these codes, they cannot be reported together unless they're performed at first 2 different encounters. That would make sense. Or at 2 different bones. So we're talking about 2 different sites or 2 separate incisions over the same bone. So if it's done through the same access, then you do not have the ability to report them together. When they're performed through the same access, then you're going to code only the 38221 for the biopsy. And then for several years, we've had this code G0364, which was specific for Medicare patients when they had a bone marrow aspiration and biopsy through the same incision. So in those cases, you were reporting the G code in addition to, say, your bone marrow biopsy code, the 38221. And then, of course, your 20220, that bone biopsy code, would not be reported with the bone marrow biopsy. So what's going to happen in 2018? Well, the two existing codes that we have are being revised. 38220 is now for a diagnostic bone marrow aspiration, and 38221 is for diagnostic bone marrow biopsy. So you see that we now just have a slight change in the description, but we still have a code for an aspiration, we still have a code for a biopsy. But now we have a brand new CPT code. When the bone marrow biopsy and aspiration is done together, we will be reporting 38222, and then that code for Medicare, the G0364, is being deleted. So whenever they're done together, we have a combination code now, 38222. So I'm glad to see that, because when I audit these, I usually find issues with them because of how the codes were structured, and then that Medicare G code. But going forward, it's very straightforward. You either have an aspiration only, a biopsy only, or you have a biopsy and aspiration together. And then if you're doing a bilateral procedure, then modifier 50 would be appropriate for any of those. So that's what is coming into play on January 1st, 2018. And just like a side note, in case you're wondering, I mean, some of you probably already looked at CPT coding changes, others of you maybe haven't gotten into them yet. But interventional radiology, for the most part, not a lot, going on there. They're very simple, straightforward, minor changes. The only major changes are in endovascular procedures, and some people consider those interventional radiology. Other people don't throw them under that umbrella. But when I say endovascular procedures, I'm talking about the abdominal aortic aneurysm repairs, the EVARs, the TVARs, the FEVARs, that kind of thing. Complete overhaul there. But other than that, not really much else going on in that area. So now that we've looked at aspiration, we're going to move on and we're going to talk about drainage. So with the drainage procedure versus aspiration, as I already mentioned, when we're dealing with the drainage codes, we're looking for evidence that that catheter has been left in place for continuous drainage. If they're placing a catheter and then they're removing the catheter at the end of the procedure, then we're going to look at an aspiration code. We're going to look at that paracentesis, the thoracentesis, or any of the aspiration codes that we were talking about, whatever may fit the scenario. So that is going to be the key difference. And when we have the introduction of some new drainage codes, which we're going to take a look at, the 10030, the 49405, the 49406, 49407. That's when the AMA started to get clear with their advice about drainage versus aspiration, because there was always kind of, an up in the air, question there. Do you have to see the catheter left in place in order to, code for a drainage? There were times when you were coding for a drainage where maybe the catheter wasn't left in place, and then they have come forth with clarification saying that the new codes actually, you need to see evidence that the catheter was left in place, that would need to be there. So with the percutaneous drainage procedures, this is where they're doing typically drainage of an abscess, or it's some other type of fluid collection, as you'll see in just a moment in the code descriptions, where they place the catheter. They'll typically do it under CT guidance or ultrasound guidance, could be under fluoroscopic, and then they're going to leave that catheter in place. So here are some of the newer codes that we have to report drainage procedures. So I sometimes get questions about different reports. How do I determine if it's, is this report a 10030, or is it a 49405, or is it a 49406, that kind of thing. So I'm going to try to break it down very simply for you in looking at the reports. So the 10030, this is for soft tissue. And where I get the questions is it's always pertaining to the abdomen pretty much. Well, if I see that they're doing a drainage, of the abdomen, how do I know what code to pick? The 10030, the 49405, or the 49406, which we're going to look at in a moment. So with the one we're looking at now, the 10030, that's going to be for the abdominal wall. Unfortunately, sometimes when you're looking at a report, there's one client in particular, the doctor is not very clear about abdominal wall or intra-abdominal drainage. He will just say abdominal drainage, and the report is very basic and there's not a lot of detail. And then sometimes we have to go back and ask and be like, okay, was this abdominal wall, or did you actually go into the abdomen and actually place the drainage catheter? So is it external or is it internal? If it's external, abdominal wall, we're talking about the soft tissue, then it's 10030. That's a big difference from, and I'm going to flip there just for a moment, the 49405 and the 49406. The 49405 is for a visceral drainage of the same things: abscess, hematoma, seroma, lymphocele, cyst. But when we say visceral drainage, we're talking about drainage of an organ, an actual organ. So we're talking the kidney, the liver, the spleen, the lung, drainage of an organ. 49406, peritoneal or retroperitoneal drainage, that is going to be for the peritoneal or retroperitoneal space where they're placing the catheter. So in summary, basically what it is, 10030 is an abdominal wall, it's external. 49405 is internal organ. 49406 is the peritoneal or retroperitoneal space. So that's the difference, organ versus space on these two. So just to jump back here, so with the 10030, it may be reported, and these rules will apply to the other codes as well. It can be reported once for each individual collection drained with a separate catheter. So if you have multiple drainage catheters placed in multiple collections, then you can report it multiple times. You'll notice that we have no RS&I component to assign with these codes. That is going to be bundled into these codes. And then, of course, they're going to require that an indwelling catheter is base. And then we have our other codes. The rules are the same. Indwelling catheter has to be left in place. Guidance is included. And then if you have multiple collections that you're draining, multiple drainage catheters are placed, then you have the ability to report the code more than once. And then just a note here, I think I put in some slides on peritoneal catheters. I'm pretty sure I did. 49406, the peritoneal code here, is assigned for a non-tunneled peritoneal catheter. There are codes specific to tunneled peritoneal catheters, so that does not apply here. This is going to be for a non-tunneled peritoneal catheter, so you want to make sure that you make note of that. And then moving on to code 49407, this is actually for an image-guided fluid collection, drainage by catheter, same code description, peritoneal or retroperitoneal via transvaginal or transrectal. So the only difference between code 49406 and 49407 is the approach. How are they doing it? The 49406 is going to be the percutaneous, and then the 49407 is going to be via transvaginal or transrectal approach. So that's the difference between those two codes. So a couple of examples. We have an ultrasound guided liver abscess drainage. In this one, we see that the drainage catheter was placed into the collection, and it says successful ultrasound guided liver abscess drain. So we are draining an abscess of an organ, a visceral organ. So that is 49405. And then in the next example, we have perihepatic drainage. Now this is where we see the difference between 49405 and 49406. We just saw an example of a liver drainage, which was 49405, but when we're dealing with a perihepatic drainage, not the liver itself, but we're dealing with a fluid collection that is on the outside, this is where we would consider that abdominal or the peritoneal or retroperitoneal space, and then we would code that with 49406. That's why I threw those in there back to back. And then for a mesenteric drainage, that would be coded a 49406 because that is considered the peritoneal cavity. So I'm not reading through all the examples in depth. You have them to go back and read through on your own. I don't like reading when I'm presenting if I can avoid it. I think it's a little boring and tedious to the audience, and it takes a lot of time to read through some of them as well. And then in our next example, this is a pelvic abscess drain via a transvaginal approach. So you'll see here that code to 49407 when that drainage catheter was placed for the pelvic abscess. And then also on this particular case study, the conscious sedation was noted for 30 minutes. So on this slide, you see the conscious sedation codes that are listed on there as well. The other prior examples didn't have it specifically mentioned. But anytime moderate sedation is performed with any of the procedures we're talking about today, you will have the ability to report that separately. So moving along, we are going to look at some specific codes, some other specific codes for drainage. So we have pleural drainage codes 32556 and 32557. Of course, when we're talking about pleural drainage, we're talking about inserting our chest tubes. And the with imaging guidance is 32557. So here's an example of a chest tube placement where we see that the needle was passed under CT guidance through the skin, guide wire was passed through the catheter and coiled within the pleural space. And then it goes on, gives us more details of the procedure. It says one suture was used to secure the catheter to the skin, so we see that the tube is going to be left indwelling. It was attached to a collection device. So we have 32557 for our chest tube placement. So chest tube is going to be the pleural drainage codes. And that's just for your basic percutaneous chest tube. We have some other codes that we have to choose from for chest tubes. So there is an open procedure, 32551 for that tube thoracostomy when it's open. And 32550 is for a tunneled pleural catheter with cuff. So that, of course, is different. And then we have 32552, which is for the removal of an indwelling tunneled pleural catheter with cuff. We don't have removal codes for the other chest tube, but we do have it for the tunnel because obviously there is that extra work involved in pulling that tunneled catheter. And in your reports, you will see these referred to sometimes as the Denver Pleurex catheters, that tunneled pleural catheter with the cuff. And then we do have the RS&I code that goes with 32550, and that is the 75989. So that's for the Denver Pleurex catheter. So those are for your tunneled pleural catheters. So just a few moments ago, I told you the code that you would use for a non-tunneled peritoneal catheter, that would be CPT code 49406. We have different codes for tunneled peritoneal catheters, which are listed for you here. 49418 is going to be for the insertion of that tunneled intraperitoneal catheter. And then these are called Pleurex peritoneal catheters. If you see that in your report, where it says a Pleurex catheter, Pleurex peritoneal, that will give you a clue. That's what you're dealing with. Imaging guidance is included. There's nothing separate to code there. And then we also have a 49419, which is an insertion of the intraperitoneal catheter with a subcutaneous port. So that's the difference between those two codes, the catheter without a port, the catheter with a port. And then we have a code for the removal of the tunneled catheter. And then we have two other codes I've listed for you here, which can be for the injection of contrast to evaluate the peritoneal catheter. So we have 49400, and then we have 74190 if an actual study is done and we have an interpretation there. If for some reason you have the injection being done and then there's no formal study, then you could have 76000 as the actual code there. But that would be when that is the only thing that's done, and that brings us to that separate procedure designation there, which I'm going to talk about in a moment. I think a little bit later I have something in there about that separate procedure. Yeah, I do, about the separate procedure designation. So tunneled peritoneal catheter, here's an example of what that would look like. So just in the interest of time, I'm not going to read through it, but you can see that this is going to look very different, your report, if you compare this to just a typical peritoneal catheter as described by 49406, you see the difference in the work that's done, you know, when we have that tunnel catheter versus just the regular catheter. So if they're not using the terminology to give you that heads up, just reading the report, you should be able to ascertain that this would be tunnel and that it wouldn't be a regular one. So from time to time, the physician will have to do drainage catheter maintenance. So before they do this, typically they may do a drainage catheter check to see how the catheter is functioning. So we have a set of codes for that. And then after the drainage catheter check, then they will do an exchange of the drainage catheter. And the codes that we're looking at here, these are generic, where you can use them for different types of drainage catheters. So they're not exclusive to one type. So drainage catheter check, when they're injecting the contrast, to do the catheter check, we have 49424 and then 76080, which is for that catheter check. And then the exchange, you see, we have 49423 and 75984 is what we're reporting for the exchange. Now notice with these that they have that the terminology separate procedure noted in here for the 49423 and 49424. And we also just saw it here with the 49400. You want to remember with CPT what that separate procedure designation means. And sometimes I see that this kind of falls off the radar of a coder, that separate procedure designation. Basically, what that means is that you will not assign that procedure in conjunction with a CPT code that describes the total procedure. So in other words, if that's the only procedure that's done, then you will report it. If it's done with another related procedure, then it's going to be bundled into that. So for example, if they do a drainage catheter check and then they do an exchange of the drainage catheter, you will not report the drainage catheter check. You would only report the exchange of the drainage catheter, or any other procedure, you know, if they're doing that is more extensive, that would involve, you know, the catheters. So that's what you want to remember with the separate procedure designation. And just a side note that I want to point out, because this is an area that people always, you know, get confused about too, is, you know, fluoroscopy. Fluoroscopy has that separate procedure designation, the 76000. And I'm not specifically talking about that today, but basically what that means is the majority of the time that code isn't going to be reported separately. Now there are exceptions to that rule in interventional radiology, or from time to time you will be reporting 76000, just like I showed you 2 slides ago. And it does happen in certain scenarios, but by and large, because it has that designation, unless it's the only procedure that's performed, you wouldn't be reporting that separately. So make sure you watch those codes that say separate procedure designation. So here's an example of a drainage catheter check, very straightforward. Contrast is injected through the patient's abscess drainage catheter, and then we have the findings for that. So since that's all that's done, it's 49424 and 76080. And then in the next example here, we have the injection of contrast was made into the patient's catheter. Findings were documented. Then it says that the catheter was exchanged. So we see that contrast injection, that catheter check first. However, because the physician went further and did the exchange, we're not going to code for the catheter check, we're going to code for the exchange. So you wouldn't assign those 2 code pairs together when you see them done. So one more point about the drainage catheters. From time to time, a patient will pull a catheter out, and then they will bring them to the department for evaluation. So they will sometimes inject contrast into the sinus tract. So patient has pulled the drainage catheter out, there's nothing in place, they inject contrast, and they're evaluating the tract. That is code 20501 along with code 76080 for a tract only. That assumes that they are not putting anything back in the tract. If they're putting something in the tract, then you either have a placement or a replacement depending upon you know, the circumstances with the patient there. And the 49424 and 76080, that's for injection into a drainage catheter. So if the catheter is still there, 49424, 76080. If there is no catheter because they've pulled it out and it's just the tract and then they don't put a catheter back in, then it's going to be 20501 and then 76080 just for the tract evaluation. So now I'm going to move on to sclerotherapy, and then from there we'll do moderate sedation. So I see I'm doing awesome on time. I am actually going to finish early today. Oh my goodness, that like never happens. Anybody who listens to my webinars, so we'll have some time for some Q&A this afternoon. Okay, so with sclerotherapy, this is kind of a very broad area. There are a lot of different procedures that could fall under that area of sclerotherapy. And basically when it comes down to sclerotherapy, clinical indication is going to be one of the main pieces of information that you want to take a look at to get yourself pointed in the right direction for the correct code that you're going to want to assign. And then you also have different methods of sclerotherapy, different sclerosing agents that may be used for these procedures. So the codes are really scattered all across CPT. There is not really one section of CPT that has these procedures. They're just kind of here, there. You know, they're in the, let's see, like some of the examples you would have would be embolization codes, could potentially be sclerotherapy. Then we're going to look at some of these codes. 49185 is kind of more a generic catch-all, and just some other codes. But we have a lot of different surgical codes that can describe sclerotherapy. So here is a code that was introduced. I think now we've had this one for 2 years. I think it went into effect in 2016, if I remember correctly. Sclerotherapy for a fluid collection. This was something that we didn't have a code to report these procedures, and I'm so glad that they came up with one. So 49185, notice it's for a fluid collection, and then CPT gives us some examples of what that may be. The lymphocele, the cyst, the seroma, those are the types of fluid collections that this code pertains to. And even though it's in the section of CPT where we're dealing with the abdomen, this is where it gets confusing. Does it only apply to those abdomen procedures, or does it apply to other procedures? And I've talked to other consultants, and the understanding is that this can be used outside of the abdominal area when we're talking about a cyst, seroma, or a lymphocele, that it doesn't have to be in the abdominal area. This is kind of more of a generic code. But most commonly, that's where you would see these types of procedures being done. So the intent of this code, if you look at it, and I think that's why they put it in this section, is because the instruction was to report this code when they're doing an ablation of the kidney, liver, and splenic cysts. And so you kind of see why that would fall into that section of CPT, but it's not, like I said, restricted to that. And then with this code, it can be reported per cyst or per collection when there are multiple seromas treated, multiple cysts treated, lymphoceles. You can report it once per collection for each lesion that is treated through a separate catheter. And then if you have multiple lesions through the same catheter, then that's going to be considered one sclerotherapy procedure. Now, sometimes with these, and like I said earlier, when I started the presentation today, I include sclerotherapy here because sometimes you'll see aspiration and drainage occurring at the same session as sclerotherapy. That's why I kind of tag it on to this, that with the sclerotherapy procedures, they do not include drainage prior to sclerotherapy. So if a patient presents for drainage and then they also have sclerotherapy performed, that they have an injection of a sclerosing agent through that catheter, then we have two separate procedures. So if the drainage catheter is left in place and they're doing a drainage, and they also happen to be using the catheter for sclerotherapy, it's two separate procedures. So your drainage codes can be reported separately with the sclerotherapy, and they're listed for you there, the other codes that you may commonly see reported with the 49185. So we have some other procedures that we would call, quote, sclerotherapy. We have 32560, which is a pleurodesis procedure. And this is where it injects doxycycline into the pleural space to reduce the space so we can't have the excess fluid collecting. What you may see with these is that a chest tube or thoracentesis, one or the other, may occur during the same session. So once again, sclerotherapy with an aspiration or drainage is something that we might see. And of course, that's not the only chest tube code possibility there. It could be one of the others. I just want to point that out. 36468 is injection of a sclerosing agent for the treatment of spider veins. That code description is going to have a slight description change for 2018, but the intent of the code is still pretty much the same, just a little bit of a difference there. That is going to be specifically for a sclerosant that treats spider veins when they're doing that extremity. And then for that, it's reported once per leg, and then ultrasound guidance used may be separately reported. Now, this is for treatment of spider veins, so this is different from venous embolization, which is 37241. So when we're talking sclerotherapy, sometimes these procedures can be referred to as embolization procedures. That's the other thing with sclerotherapy, the terminology, embolization versus sclerotherapy, or some of these other terms that you're seeing in code descriptions. That's why I said sclerotherapy is kind of a broader term that encompasses a lot of procedures, and then you have more specific types of sclerotherapy under that umbrella. But in the case of spider veins, we have 36468 for that. It's not a venous embolization. It's described by 37241. That would actually be for venous malformations for 37241. And then moving on with the extremities, we have 36470 and 36471, which is for injection of a sclerosing agent to treat varicose veins. So different purpose. So for this here, once again, 37241 is not going to be reported for this. The 37241 is for, as noted on the bottom of the slide, venous malformations, mainly that any hemangiomas they're treating, varices, lymphatic malformations. That's the purpose of that. Sometimes with these procedures, you'll see that they're using foam agents. And people are used to, when they see these foam agents being used, that would be an embolization procedure. That would not qualify for 37241 as an embolization, just to kind of drive that point home. So you should not see these codes, 36470 and 36471, or even the prior code, assigned along with 37241 for the same vessels, for that same surgical field. And then here's something that's a little bit awkward in its coding. So we have lymphatic malformations. If a lymphatic malformation is primarily lymphatic, then that would qualify for 37241. So that is when you would use that. So we're not talking lymphoceal, which would be the 49185 we looked at. Lymphatic malformation is when we're talking about a vascular malformation is 37241. And then along with that come all these kind of things that fly in the face of like IR coding rules. If you have diagnostic imaging that's performed, if they're doing the lymphangiograms, we have the 38790 for the injection that goes with that, and then the imaging codes. If they're injecting somewhere where there is no code, then we have them listed. And then if they are gaining needle access, but they're not doing the 38790, that's unlisted. And then we also have the ability to code for the ultrasound guidance with these procedures. So it's just a little bit, these are a little bit goofy, the rules when we're talking about lymphatic malformation embolization. So I wanted to throw in a slide on that. So here's an example of lymphoceal sclerotherapy. You see here that alcohol sclerotherapy, the patient had it in the past. They decided to use a different sclerosant. So here they use doxycycline to do the procedure to treat the lymphoceal. So now this is in the groin, and it's 49185, even though it's in the groin. So it's not one of the things that was listed specifically for 49185, but that is the correct code. And then on the next slide, we have a lumbar seroma where sclerotherapy was performed. And so this one was performed with the ethanol, and it's a seroma, and it was in the lumbar area. It's 49185, would also be reported for that. So like I said, it's not specifically noted in those areas that I had on the slide, but it is appropriate to report for those. So briefly, let's just hit on moderate sedation. I'm only going to spend about a minute or two on this, and then we'll go over to Q&A and see if anybody had any questions. So this year we had some new codes for moderate sedation, and prior to 2017, moderate sedation was included in almost all of our interventional radiology procedures, and we didn't have to give any thought to it as far as our coding is concerned. Well, in 2017, we have to account for that. It should be documented in the reports so we can pick up the codes that we need. And it's something that even now, I mean, 11 months in, I'm like, shoot, I sometimes forget, and I got to go back and I realize, darn it, I'm missing my moderate sedation codes. Was it, you know, that I didn't see it in the report, or did I forget to check for it? You know, whatever the case may be. But we have essentially two sets of codes. We have moderate sedation codes when moderate sedation is provided by the same provider as the one that is actually performing the procedure. So those are the ones that you're probably using day in and day out. We have 99151, which is younger than 5 years of age, 99152, age 5 years or older. Either one of those is for the initial 15 minutes of intra-service time, and then 99153 is for each additional 15 minutes. And then our second set is for an other provider. So this is when the sedation services are provided by a physician or another QHP other than the one performing the diagnostic or therapeutic service. Then we have the other codes to choose from, and that's really the only difference from the first three that we looked at. So just briefly, rather than going through all of the components of moderate sedation, when you're calculating your time, you want to remember that the time is based on your intra-service work. So what does that look like? Well, your intra-service work, that time for calculating moderate sedation for coding purposes, you will look at what time the sedating agents were first administered. That starts your clock. And then it's going to end when the procedure is completed, and then the patient is stable for recovery, and then the continuous face-to-face time with the patient ends. And then you'll also note that it includes the ordering and administration of the initial and subsequent doses of sedating agents. The key is it requires continuous face-to-face attendance of the physician or QHP, and that it begins with the administration of the sedating agents. So when you're looking at your documentation, a procedure start time and a procedure stop time doesn't necessarily equate with moderate sedation start time and stop time. So make sure that you are paying attention to that, because oftentimes it's going to be different than what the procedure start and stop time is. And hopefully in the report, the physician will give you language as the coder. I'm not a big fan of taking documentation from flow sheets that are coming out of the department. Now the department may be charging it, you know, where the procedure is being done. So certainly it would be there. HIM, you may not even be touching that or doing anything with it. It might be a department responsibility. But even with that said, I think that the physician should have the required documentation in the report. The moderate sedation requires that they monitor the patient response, that they assess the patient, O2 stats, heart rate, and all that. Certainly that would be, you know, in the record for the department and not necessarily in the operative report or somewhere else in the medical record. But just to give you an idea of what you would want to see in the report, here's one example that says, the procedure was performed with conscious sedation and analgesia under my direct supervision. Continuous blood pressure, pulse oximetry, as well as heart rate monitoring was performed by an independent registered nurse. Physician intra-service sedation time was 180 minutes. So that's one example of what it might look like. Oops. Here's another example. Boy, did I get ahead of my, how did I do that? I must have hit the end button. Here's another example. The patient was monitored with pulse oximetry, blood pressure cuff and EKG, leads by a registered nurse. IV conscious sedation was performed under my direction and supervision using 1 milligram of Versed and 50 micrograms of fentanyl, intra-service time of 30 minutes. So the example I gave you here didn't specifically mention the medications. If they're not in the statement, then they should be documented somewhere else if they're not specifically here. But those other components is what you should see in the report, and there should be a clear definition of the total time by the physician in the report as well. And then here on the next slide, this is just a table that's put together for you, quick reference to refer to for your total time. An important point to note with moderate sedation, if the physician uses less than 10 minutes, then you don't code for any moderate sedation whatsoever if it's less than 10. And typically the only time I see less than 10 minutes is if they're placing a central line, you know, they're placing the PICC line, or they're placing, if they even use it for a PICC line, you know, a tunneled, you know, catheter, you know, it could be, you know, less than 10 minutes, you know, things of that nature. But for the most part, your IR procedures are going to be over 10 minutes, unless it's some of the basics or some of the biopsies might be less than 10. So the simple procedures. So that brings us to the end of the program. And before I flip it back over to see if we have any questions, I just wanted to share this. This was an offer that I made last week when I did a webinar for FHIMA. And so it's still going on. And so for a few days, so I wanted to throw it out there to people in the Northeast region if they're interested. This is exclusive for FHIMA members. All of our other discounts for the general public ended October 31st. So my reference book for interventional radiology, that 800-page reference manual, that monster that I wrote a couple of years ago, you can still get 20% off. Also, if you're looking for a CPT coding update just for radiology, we also have that available as well. And so that will be good through this Friday if you want to take advantage of that. So why don't we see if we have any questions? Jerry, did we get any questions?
We do not have any questions at this point in time. Does anybody have any questions?
I cannot believe there are no questions. Everybody must be shy today. Well, if you think of a question, I know what happens sometimes when you attend a webinar is you go back and you start to digest the information, then you have questions, like as you're doing your work. So if something comes up and it you know, pertains to today's webinar, please feel free to send an email to the email address here on the screen. For one thing I would ask is when you email that info@radrx.com, that you put in the subject line that you attended the Northeast, you know, FEMA webinar, because we don't respond to questions via email unless you have a paid Q&A contract. So, but if you specify in the subject line you attended today's program and then put your question, then those questions will get forwarded and then I will respond to them if you attended today's program. So thank you so much for your attention.
I'm sorry, you hear me? Hello?
Yeah, I've unmuted everybody, so if you do have any questions, Stacie, I'm sorry. It sounds like we may have one. Who's this?
Okay.
Yeah, this is Mona. Mona, I just was like trying to download like the app for Go Meeting, and I wasn't able to download it. So and after that, I just typed the number. I just need to mention that. So this has happened last time too. So I just mentioning that like I wasn't able to download the app. I'm on my iPhone.
Okay, that's fine. Thank you, Moni. We'll have to figure out what's going on with you with that. Anybody else? That sounds good. Okay, I think that's about it. And you know, Stacie, we definitely appreciate everything that you did here today. My head's spinning just trying to take it all in. So please, absolutely, if anybody does have any questions, you know, like Stacie said, let's get them directed to her and make sure that you mark that you were on the Northeast NEFHIMA webinar today so we can get the answers. And, you know, if anybody has Any other comments? Or, you know, and again, please remember, if you called in and you were not able to log into the website, please make sure to email either Lee or myself to let us know that you were here so that we can get you your CEU sent out. And everybody, have a great day. Thank you very much. And thanks again, Stacie.
Thank you.
Okay,
Bye-bye.
thank you. Bye.